Health Minister Dr Joe Phaahla says it costs more than twice as much to train medical students in Cuba than in South Africa. South Africa has been sending medical students to Cuba since 1997 under the Nelson Mandela-Fidel Castro training program, with costs carried by individual provinces. The program has been controversial from its outset and is currently under scrutiny from the Democratic Alliance. Students spend their first year in Cuba learning Spanish and then do 5 years of training at Cuban medical schools. For more on this, we're now joined by DAMP Haseena Ismail, Professor Shabir Madhi of the Wits University, as well as a member of the South African Medical Association, Mzulungile, Nodikida. Good evening. Good to have you with us, and thank you very much for your time. Haseena, let's begin with you. Is the Cuban program the answer that we need for South Africa, a shortage of doctors?
Good evening, everybody. I certainly do not believe so. I feel, we could be using that money constructively by, actually training our students in South Africa within its borders. I think if we're looking at just the costings, as you've just stated now, it actually works out to double the cost of each student being, studying actually in Cuba as compared to studying in South Africa. And, even looking at what our students actually have to bear with in Cuba, I think, it would be more viable to actually train these students within the South African borders.
Yeah. Mzulungile, from someone who's been in the program, what's your feeling? Is this something that South Africa should continue to fund as it addresses the shortages of doctors in the country?
Right, I'm afraid the South African Medical Association is not in a position to decide whether to fund the program or not. But what we do acknowledge as the South African Medical Association is that there is a global shortage of healthcare workers, specifically doctors. And South Africa, the government took a decision to send students to Cuba. But South Africans are studying medicine all over the world. And that's not because they want to. It's because the medical schools in South Africa are just too few for the population and the students that, without the Nelson Mandela, the new medical school in Port Elizabeth, you literally had less than 10 medical schools in South Africa. So it's not a question of some would like that program to continue, because that's not a program of the South African Medical Association. But we welcome every effort that looks at addressing the shortage of healthcare workers in the country.
Yeah. Okay, let's put it this way. As Sama, do you think the money that South Africa is spending, because they've made the decision to fund this program, is being appropriately used or could be better used in the country? For example, if we were to build more medical training places in South Africa.
Look, that's one of the reasons why we are welcoming the idea of incorporating the program within South Africa. I can tell you, no one wants to study medicine outside of their own country. But the fundamental thing to remember is that medicine is the same wherever you go. Basic sciences of medicine are the same. The only difference is the question of the disease profile, which is what is different between Cuba and South Africa. But I can tell you, as somebody who's gone through that program, that one of the strengths of the program is the primary healthcare orientation of the program, which is incorporated from first year of study up until the 5th year of study. Now, if you globally, there's evidence that if you focus on primary health care and sort out 80% of your problems at that level, you are likely to have a more affordable health system, which is what I think South Africa needs. So, but it can be a copy and paste. Cuba is an island. South Africa is got 50 million. In Cuba, I think there are just over 14 million people. So you would need to pick the things that you think work for you and the health system, just like everyone is doing. everybody is copying the Cuban system in terms of their strength, and they are incorporating it in their own health system.
Yeah. Professor Madhi, let's look at those three areas. One, except for the question of the tuition cost, to the availability of training centers, the argument is what Mzulungile has just outlined now, that the reason why we send our students to Cuba is because of that orientation towards primary health care, where they seem to be a little bit stronger, and we could certainly use that and benefit from it.
Good evening. So I think there's a few issues that we need to unpack. So certainly in 1996, when the program was initially conceptualized, the number of doctors that we've been produced by the medical schools in South Africa was less than 1,000. That number has now changed to close on to 1,900. The University of Witwatersrand, where I have been since 1985, when I graduated, we graduated 220 doctors each year. And nowadays we graduate 380 doctors each year. So the capacity to train doctors has increased substantially since 1996, when the program was first conceptualized. And over time, the program is actually being phased out, or is supposed to be phased out. Is it justified to spend twice as much to train a doctor in Cuba, and this is public funds, compared with investing in training doctors in South Africa? Certainly not. We do have the capacity to train doctors in South Africa, and there is efforts to actually increase the number of medical schools beyond the 10. The University of Johannesburg, as an example, has been awaiting feedback from the Department of Health to open a medical school at UJ itself. So there is potential to have more medical schools in South Africa. But other problems that we face is not so much that the Cuban doctors have got a different type of primary health care exposure. In fact, the curriculum in South Africa has been changed significantly since I trained in 1990, and we've got a significant component of primary health care integrated into the curriculum, in addition to which South African doctors get an additional 6 months of just primary health care exposure as part of the internship. So the justification that you're getting a more primary health care centered type of training in Cuba, I think it no longer holds true. It might have held true in 1996 when the program was first conceptualized. But the bigger issue is that right now we've got this contradiction in South Africa, where even the number of graduates that's actually being produced in South Africa, the public health sector is no longer able to actually absorb them. In that there are a number of doctors that are wanting to stay in the public health sector, but there aren't sufficient posts after they've completed a community service to remain in the public sector because of the shortage of funds. So despite this, we've got this contradiction that on the one hand we say we've got a shortage of doctors, but on the other hand, there aren't actually any posts available in the public sector for doctors. Now, compounding all of this is when we talk of primary health care, doctors are not necessarily the best health care cadre that you're wanting to provide primary health care. There's another category of individuals known as clinical associates or physician assistants, which the Department of Health asked universities to actually start training way back in 1996 as well. Those clinical associates that are being trained, and since the start of the programs, it's about 1,600 of those that have been trained, they've got absolutely no position in the public health sector. They're not being accommodated. Now, these are important cadres of healthcare workers and can make a substantial impact in terms of providing primary health care at a much lower cost than what it costs to have doctors providing primary health care. Yeah. So there's a number of moving parts, but the short answer, certainly in this day and age, in the year 2022, there's absolutely no reason for South Africa to be using taxpayers' money to send people to Cuba to be trained at double the cost of what it would cost to train those individuals in South Africa.
Let's take a break. When we come back, we'll take your thoughts as well. 072-110-5584 to this conversation. Is the Cuban program still necessary? Is it the answer to the question of the increasing shortages of doctors in the country? Or as Professor Shabir Madhi says, actually, there are plenty of doctors who are actually not being placed currently, who are qualified to do so. Maybe the challenge could be that the taxpayer money that we are using to take students to Cuba could be used to hire those doctors who are currently not being placed. What are your thoughts? 072-110-5584. Stay with us. Back with you tonight on In Focus, still with DAMP Haseena Ismail, Professor Shabir Madhi of Wits University, and Mzulungile Nodikida of the South African Medical Association. Your thoughts tonight? 072-110-5584. Haseena, Firstly, the 370,000, I believe you're saying it's part of it. There's still more that the department spends, including on a 2 set of return flights, as well as sending officials and psychologists to Cuba to deal with emergencies. What emergencies?
Yes, well, let me just comment on that quickly. I have a few other thoughts that I would like to mention. So basically, if there's a medical issue that's taking place, with one of these medical students in Cuba, obviously, a medical treatment needs to be, medical aid needs to be, carried over to Cuba. And in some cases, I'm told even, when it comes to mental health, etc. And these are all issues that are, again, although it's, it's on humanitarian grounds, however, it is still, again, an increased, amount to the taxpayer. So the reality here is that, I think you've given a simple breakdown, but if I could just specify, $14,872 for the preparatory year, $21,422 for each of the first 2 years at medical school, $20,422 for year 3 and 4, $22,522 for the final year in Cuba. And on the return, it costs 130,348 rand per semester at a local medical school for the year to June, for the year to June 2022, and 138,820 rand per semester in the year to June 2023. That's what we're looking at now for the future. All this, if you contrast or you compare to, somebody that actually graduated in South Africa, maybe Professor Shabir can correct me, but I could think we could estimate it to plus minus 150,000 rand per year to train medical students within the South African borders. At the same point, I just want to bring in the fact that I think there was an article in June earlier this year, 1,900 first-year places are available at South Africa's 10 medical schools. So while we can obviously say that we have a shortage of maybe medical schools, but the fact that we have openings and at the same time are still sending our students to Cuba doesn't really make logical sense. Another issue that I would like to highlight, in my oversight visits to all our hospitals, or at least some of the hospitals throughout the country, each and every CEO highlighted that during the COVID period, all our comm service and interns that actually assisted during this time that were laid off due to the, the departments saying they don't have enough budget to now pay these comm service and interns. These hands are sorely needed right now. We have a shortage of doctors. We have a shortage of theater nurses. Basically, each and every hospital, is short-staffed. So the reality is that by spending all this money on medical students going to Cuba, all that monies could be effectively assisting our healthcare system right now, immediately in increasing staff at our hospitals.
So as a Democratic Alliance, sorry Haseena, are you arguing that we don't have a shortage of medical training colleges?
I wouldn't necessarily say state out that we don't have a shortage of medical institutions. I'm saying that what we have can still assist in, including these students within what we have. And I would say that the monies that we are spending on the Cuban, program, or, the Nelson Mandela-Fidel Castro collaboration program could more effectively be used in, in creating more medical institutions so that our students can actually be trained within the borders of South Africa, and it would cost the taxpayer half that amount.
Yeah. Is this
most especially considering that, year in and year out, we have our provincial budgets that are cut.
Yeah. Is this in any way connected, I suppose, to the kind of exchange relations that we have with Cuba? I mean, Dirk, at some point we're talking of taking some millions over as part of the humanitarian assistance that we are offering to Cuba. Or is there some legal binding contract in place that guarantees the continuation of this program?
This is a question that I would like the answer to. I've been requesting at our Portfolio Committee of Health that please could we get a full report on this program so that we can actually, interrogate it and look at exactly where we are with this and what is the underlying factor that is, I would say to a large extent in inverted commas, forcing South Africa to actually have this program, in its place. And, when you're looking at Cuba in particular, I mean, if you're just looking at the cost of the Cuban brigade, never mind our medical students going into Cuba, but if you're looking at the Cuban brigade and the amount of monies we're actually spending on the Cuban brigade and Cuban engineers coming into the country, it's really causing megabucks to the taxpayer. And especially when, we could be using all that monies to actually pay our comm service doctors and interns that are actually waiting for positions. I mean, at this stage of our country, especially after COVID with the unemployment crisis and, obviously the cost of foods, increase of, food prices, etc. I think all that monies could be more effectively used to keep or to rather employ our, waiting comm serve and interns and give them actually placements that they require instead of them sitting at home and unemployed.
Yeah.
The reality is that we only got 2,617 students. Actually, is the final number that, if I could say, they graduated since the inception of this program, and that is very little compared to the amount of monies that we actually spent for the students there.
Yeah. Mzulungile, from the South African Medical Association's point of view, the population that has got to be serviced by the doctors and the current numbers of doctors that we have or that are graduating out of the system, does it match? Will you be able to meet the demand?
No, as we speak now, South Africa is sitting at, I think, 0.9 per 100,000. So that is far less, and this is not unique to South Africa. It is unfortunate that you have doctors sitting at home when you have a population that needs them. I think the fact that there are doctors that have graduated and are in excess are not appointed is an indictment, because that does not eliminate the need, especially in the deep rural parts of our country. I think it's easy for people to talk about access to healthcare in South Africa, and the fact that if you are in the rural areas of South Africa, if you are lucky, the doctor that you will see is a community service doctor because of the community service program. So I think for us as the South African Medical Association, our mission talks to uniting doctors for the health of the nation. So that's basically what we do. And the Cuban graduates are no different. They are doctors. So we would like to use whatever they've learned in the country to try and improve the health system in South Africa. And I think one of the things that we support is the indication by the ministry that they would like to take it further and take some of the good things from the Cuban program and incorporate them in the training of the medical students in South Africa. Yeah. And as the Prof said, the deans of medical schools in South Africa already have a yearly meeting with their Cuban counterparts. So if you can learn anything from anyone, you take that and incorporate it as long as it's going to benefit the nation. So for us, it's about the health of the nation. That's what's our mind.
Yeah. Professor Madhi, as far as the quality then of what we are producing as far as medical students in the country, are there any questions around that?
Certainly not. And as I mentioned, the curriculum has undergone a substantial revision over the past 2 decades, where we do have a primary healthcare focus included in the curriculum. But importantly, after completing 6 years of medical school, those graduates are not let loose on the public in a sense. They actually go through a further 2 years of sort of supervision, what we refer to as an internship. And during that period of time, they're getting exposures, including exposures in the rural area to rural medicine, and they're also working in primary health care settings. But again, I think the big issue that we're facing, which we're sort of shying away from, is the reality is, yes, South Africa doesn't have the per capita number of doctors that is recommended by WHO, but at the same time, as I indicated, we got this contradiction in that we're training doctors that simply are not being accommodated in the public healthcare system now. Training doctors, more doctors, doesn't mean we're going to get more doctors into the rural area. As an example, at Wits University, 20% of our entrants are reserved for people that come from the rural area. Unfortunately, when it comes to where people choose to go back after they've graduated, doesn't necessarily mean that if they've come from a rural area, they're going to go back to the rural area, although that is more likely. The big issue that we're facing is we need to have a clear vision in terms of what type of care we're wanting to provide. And yes, our healthcare services, the backbone of it should be primary health care. And then we need to ask a bigger question is, which is the appropriate cadre of healthcare workers that we need to train to provide efficient primary health care? And again, I will emphasize, doctors are not the backbone of primary health care. The backbone of primary health care are nurses, and what they also refer to as clinical associates, which fall between nurses and doctors. So we really need to rethink what we're trying to do in a country in terms of providing efficient services, especially at a primary healthcare system, and which cadre of healthcare workers are most suited and would be most cost effective to provide that healthcare.
Yeah. The Department of Health, I think it was in 2013, Prof. Madhi, you would probably recall, had a plan, for example, to turn more hospitals into academic hospitals. The minister then saying this way, in particular, the sector would be able to centralize its work, and therefore patients would be getting better treatment coming out of that. Is there some kind of value in particularly that, and maybe even being able to bring in more doctors to serve in those academic hospitals?
Well, there's two issues. The one is the centralization of academic hospitals under the National Department of Health rather than them reporting to provincial health. And that has got Ismail's vote when it comes to the governance of this facility, as well as those facilities being shared across provincial boundaries. Because in some provinces, unfortunately, you do not have medical schools, you don't have tertiary level hospitals, which is where the academic hospitals are usually based. So bringing it under National Department of Health control certainly would benefit both access to care as well as governance of those facilities. But the other issue really speaks about, again, does that mean that we're going to provide better access to health care more generally? Those academic facilities are not primary health care facilities. They are where we train people to get exposure to primary health care, but also specialist health care. What we're needing to do is strengthen primary health care, and that goes outside of the realm of academic centers. And that is where we need to focus, and what WHO recommends be done in countries, not just such as South Africa, but even in high-income countries. And I think COVID-19 is a good example where when we've got weak primary healthcare systems, our healthcare system is not resilient, and then we end up struggling in dealing with the amount of disease that we experience.
All right, let's take some thoughts coming through on WhatsApp, 072-110-5584 from Kandla. This is one coming from Taminkosi. Tami saying the Cuban program is very relevant. I know of so many doctors who have qualified in Cuba. The truth is we don't have enough medical universities in our country. This is especially important for our many poor people. Haseena, Taminkosi seems to believe that the program particularly helpful in serving poor communities. I mean, do we have any kind of report, plan, research available as to what actually happens to those Cuban doctors once they get into the country and where they go and serve, and whether indeed those communities are reaping the benefit of the investment that we have made? Haseena?
I can come in.
Yeah, we seem to have lost Haseena there on the line. Mzulungile, you can come in.
Yeah, so I just want to say two things. One is that Prof says the developing countries are also focusing on primary health care. I can tell you, Thabo, that in 2019, 3 of the Cuban graduates who are South Africans were invited by Imperial College in London to form part of an advisory team that would advise the NHS, which is the national health system in the UK, on how to do a primary healthcare almost focused approach. And that is based on the Cuban model, the way they train students in terms of what they call community diagnosis. So the team from Imperial College wanted to collaborate with South Africans trained in Cuba to make sure that look at the fact that we've already trained doctors in Cuba. They are here in South Africa. So what we need to do is to focus on the strength of the program and just make sure that it benefits the country as a whole.
Yeah.
So I'm in the Eastern Cape, and I can tell you over 80%, if not 90% of the doctors who were trained in Cuba, all of them are in the public health system. And in the main, they are in the rural areas of the Eastern Cape. And most of them are actually playing very good leadership roles in primary health care settings, PHCs, and the district hospitals. And they sometimes do what they call community diagnosis, which is what is part of the training in Cuba. And they are trying to help out the communities out there. So there will be different views on the Cuban program and its relevance in South Africa. But I think the patients would probably be the best people to judge. But from a medical association point of view, those are doctors, and we would like to unite them for the health of the nation.
Yeah. Professor Madhi, I'll get you to answer. But Haseena, here's another one on WhatsApp as well from Anonymous. And I think you are back with us there on the line. If you could respond to this one on 072-110-5584. Good evening, Putabo. The issue with our universities is far more than just blaming government. The systems of apartheid are still there. Training our students in Cuba has helped us as a country. South Africa trained doctors are village haters. Here's the other question, and I suppose Mzulungile is also raising that issue that most of the Cuban-trained doctors are the ones who are in our public health system and are particularly in the rural areas, where else Anonymous here is saying South African-trained doctors do not like to work in those villages. Haseena?
Hi, sorry, I think I've just lost you a little while there with the connectivity issue. Look, I suppose everybody can look at it in a different way, but I look at it in a way to say that we have South Africans that actually sometimes due to restrictions of, or you know, the pro rata system, or you know, the choice, if I can put it, by the ruling party to be able to decide how many of each race is actually going to be incorporated into our universities, actually force, quite a bit of our students to actually go and study overseas. And obviously not in the Cuban program or the Nelson Mandela-Fidel Castro program, but I mean we have so many of our South African children that actually go overseas to go and study medicine because they don't get the opportunities within our own universities. So there's a flip side of the coin, if I can put it that way. When it comes to, primary health care, I think, I also asked quite a bit of questions to the minister with regard to nursing colleges, etc., and, our training modules. And I think when you're looking at primary health care, I think these are actually quite essential as well. The bottom line is that when our students go to Cuba, what type of living conditions are they actually living in? I had, I think it was just pre-COVID or just after COVID, I had some connection with the Cubans, our medical students there in Cuba, and they were complaining that they don't even have food to eat. Now we know realistically, naturally, there's a shortage of, a variety of food there, but we have simple things like, basic sanitary pads that, our girl students actually don't have access to their basic human right, if I can put it that way. And all because of what? Now, I'm not taking away anything from this Nelson Mandela-Fidel Castro program, when it comes to what they are actually gaining. I'm just saying that the monies that are being spent there, considering that we are not getting direct replies from the minister, I mean, even the replies that I'm receiving from the minister in 101 questions that I'm asking are so vague. There are obviously allegations of audit reports that actually show mismanagement and, allocation of these bursaries that are actually, allocated to the wrong people, for want of a better word. So, there was the minister responded to me that there was an SIU investigation. Then my counterparts at Gauteng Provincial Legislature, which I asked them to do some follow-ups, they said the Premier's office is dealing with it. There was a provincial treasury audit, on this, and we are waiting for those outcomes. So the basic point that I'm making here is that the cost to the taxpayer right now, our economy cannot, we need all the monies that are available in our fiscus to be spent, logically, to be spent on where it's necessary. And if this medical Cuban program is actually costing our taxpayers double, we should rethink this whole matter. As Professor Maria said that, we can actually accommodate these students. And yes, we do agree that there's a shortage of doctors, there's a shortage of nurses, etc., etc. So if there's an opportunity for them to be studying in the country at half the cost, the balance of the half of the costing can be adequate enough to provide more nursing colleges, to provide more training colleges, and also to actually adequately use that monies where they need to be used. More com service interns can be placed, etc. So really, it's the way you look at it, and I just look at it in a manner to say monies meant, for the people of South Africa must be used amicably, must be used in a manner that should be more productive for the country as a whole.
Professor Madhi, we'll give you the last word. One, the medical association is important, but let's also take this WhatsApp from Lesego so that you can respond to both of them as we close this conversation. Lesego in Pretoria saying, it's really sad to see professors like Professor Madhi deliberately being economical with the truth. 10 years ago, when I did my postgraduate in health systems management, SA needed between 3,000 to 5,000 doctors a year to meet the nation's needs. He is saying that we are producing 1,900 per year and claims that is enough. It was not enough 10 years ago. Surely it can be enough now. The South African training program is far from being primary healthcare orientated.
I think we're confusing issues. Are we training enough doctors? We're not training enough doctors. Are there enough posts in the public sector, especially in the primary healthcare sector for doctors? The answer to that is no, because of the fiscal constraints that government is experiencing and has been experiencing for the past decade. Are we training more doctors than 10 years ago? Definitely we're training many more doctors. At Wits University alone, we've almost doubled the number of doctors that we've trained in the past 2 decades. So we need to be clear about what is the issue that we're trying to address. The issue that we're trying to address, firstly, in terms of the NMFC program, is the type of training that's provided through the NMFC program resulting in a doctor that has got any different competency compared to the doctor that is graduating from current day medical schools in South Africa? And the answer to that is no. And essentially what we've got is that NMFC students come back to South Africa. They need to spend another 1.5 years in our universities to get exposure to the local burden of disease. And that's what they eventually end up needing to treat. And our doctors are equally competent in training in treating that component of it. Again, we need to ask ourselves, when we talk of primary health care, are doctors the backbone of primary health care? And I would contend doctors are not the backbone of primary health care because they're too expensive to start off with. And as has been mentioned, they're sometimes reluctant to go to those very areas where the need is greatest. What we got is we've got the other category of healthcare workers that are being trained, that are simply not being accommodated in a primary health care, and they would be able to provide a much more efficient service at a much lower cost. And those are the clinical associates. So there's a number of issues that are sort of being brought together, which don't necessarily speak to the main issue that we're discussing now, which is the NMFC program, and it's unjustifiable to be training doctors for the NMFC program at double the cost compared with what it would cost to train the same doctors in South Africa. And as has been mentioned, over almost more than a 20-year period, the number of doctors that have been trained to the NMFC program is 2,600. South Africa graduates 1,900 doctors each year. So we just need to let the numbers speak for itself and talk about the cost effectiveness of training doctors outside of the country as compared to investing within the country, including possibly opening up another medical school. But it's not only about doctors, it's also about clinical associates, it's also about nurses, and those should form the backbone of primary healthcare provision in a country.
Professor Shabir Madhi, appreciate your time. Mzulungile, Nodikida, thank you very much for coming on. And Haseena Ismail, Democratic Alliance Member of Parliament, as well, for joining us tonight. Let's close off then with this WhatsApp message coming from Sinelungelo Dlamini, saying government should place clinical associates in the primary healthcare system of South Africa. I am talking clinics, CHCs and district hospitals. Also, the government should also revise the scope of practice for clinical associates. Agreeing there with Professor Shabir Madhi, and that's where we leave it. Recapping your leading stories tonight on In Focus when we continue next. Stay with us.